So with that said, I'm happy to go ahead and open it up for questions and hopefully be able to answer anything specific someone may have.
Thank you so much. We're now going to begin answering questions submitted during today's presentation. And as a reminder, you can still submit text questions to today's presenter by typing your questions into the questions pane of the control panel. If you prefer to ask your question verbally, you may raise your hand by clicking on the hand-raising icon on the control panel, and we will unmute you so you may ask your question. Also, please enter your audio PIN, which can be found in the audio section of your control panel, so we may unmute your line. Asking the questions today will be Dan Actor, Director of Marketing at EKOS.
Thanks. Let's see, we've got a lot of good questions rolling in here. We've got a couple on diagnosis. So first, the first question is, part of the challenge of treating DVT is having it properly diagnosed and then referred for treatment. Can you elaborate on the process in your institution?
Yeah, so that's a very good question. So as all of you know, one of the problems is most DVTs are diagnosed by venous ultrasound, and typically most labs and most hospitals, the ultrasound techs do the venous Doppler from the common femoral vein and down. So they really rarely, except for in some certain labs, rarely look up proximally into the external or common iliac vein. And so generally speaking, we're left with really a loss of information or diagnosis of what's really a very important area within the venous system, which is the proximal bed of the venous system. So I would say, unfortunately, we have to do what we have to go with what we have. And so what I typically do, I rely on the venous ultrasound. I look, is there common femoral vein involvement, which all venous ultrasounds will put, because that's part of a standard report. If they have common femoral vein involvement and they have significant symptoms and they have no contraindications, that is a proximal DVT by definition, and I discuss the options of treatment with the patient, and I tell patients a lot of times that when you have common femoral vein involvement, it's very, very common to see associated even more proximal involvement, and also in addition to that, a lot of these patients have, as I mentioned, venous anatomical abnormalities such as venous compression syndromes that led to this from the get-go, and that can only generally, in my opinion, can really only be diagnosed by doing intervention, doing venogram and IVUS, because venous compression syndromes are dynamic syndromes. Even CT venogram can be used, but CT venograms are not, or MRVs are not as good as intravascular ultrasound, and that's been shown. And therefore, you really have to actually go in and do the intervention and do IVUS to really make these diagnoses appropriately. Once again, highlighting why it's so important to do DVT intervention, because you can really do it no other way to get the appropriate diagnosis made and the appropriate treatment for the patient.
What I was saying on mute was that that leads in perfectly to another question I was asked about. Let's see, for interventional cardiologists who use IVUS regularly in the coronaries and PAD beds, do you have any comments on how venous IVUS is different or any pitfalls?
Yeah, so my answer to that, if you're well versed in using intravascular ultrasound in the coronary distribution or the peripheral arterial distribution, it's going to be unbelievably easy to adapt it in the venous system. The one thing that you have to, of course, know is, number one, you need to use a 035 system. These veins are very large, especially in the iliac or IVC, or I'm talking 16, 18, 20, 22 millimeter stents. So you can't use the 014 coronary IVUS. That will not show you appropriately the images you need. Number two, you do still have to somewhat get comfortable with the concept of venous compression syndromes, and that, I tried to highlight and show a couple of cases just to show how it looks. But if you are comfortable sizing and comfortable using IVUS in the coronary distribution, it's very easy to proceed with IVUS in the venous system. It'll actually be very, 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 very simple for you to make that adaptation appropriately and do it in a skillful manner.
Okay, great. Let's see, next question. What do you think of some of the clinical prediction scoring methods for DVT diagnosis, like the Wells score or D-dimer tests, maybe in place of doing a venogram prior for referral?
I mean, I think those are all useful for making the diagnosis of DVT. They're unbelievably unuseful for helping treating the DVT. I mean, those are useful to decide, do you need to do further testing to diagnose DVT. But where my issue is, once you have the diagnosis of DVT, a lot of people pat themselves on the back after they give a patient anticoagulation thinking they did a good job. Well, in my opinion, if it's proximal DVT, you did not do a good job. 30 to 50% of patients with left-sided DVTs have a venous compression syndrome causing it. If you didn't treat that, that's a symptomatic compression syndrome that should be treated. And if it's not treated, then you did not fix the underlying cause. And so a frequent presentation, I've seen it many times, young female comes in with a left lower extremity DVT. She gets placed on Coumadin or a NOAC. For 6 months, 1 year, the NOAC or Coumadin stopped. 2 years later, comes back with another extensive DVT. Hypercoagulable workup is done, all negative. Everyone's sitting there scratching their heads. Why in the world is this patient getting recurrent DVTs? Ultimately, patient end up having a venogram and IVUS. Lo and behold, she has severe May-Thurner. And so this patient for the last 2 years had recurrent DVT, extensive, potentially could have had a life-threatening PE that was not treated appropriately on day one when she presented. And that's why it's very problematic in my mind not to look for these things, because it is so common. It is unbelievably common to find venous compression syndrome. I think it's actually personally much higher than even the numbers that I quoted initially. That's just what the data shows.
Okay. Let's see, next question is about fibrinogen. What's your experience with fibrinogen levels? Do you monitor them? And then do you experience a dramatic fibrinogen drop in your DVT patients? If so, does this impact your TPA dosage?
Yeah, that's a good question. I get that question almost always when I give these lectures. So fibrinogen, I used to be, I used to actually check fibrinogen levels and titrate the dosage based on that. And I found the only thing it does is it induces confusion, and I don't think it really changes efficacy at the end of the day. So I would say about 4 years ago I stopped doing it, and I just set the drip at whatever the thrombus burden is. 1 milligram an hour for 12 hours, for 6 hours, for 8 hours, just depending based on kind of my assessment of what the thrombus burden looks like, and then that's it. I found once you start inducing complications in the sense of making things complicated for nursing staff and others, it really makes life much easier, and I really don't think there's much data to support that fibrinogen and changing TPA makes a difference in terms of thrombolysis and efficacy at the end of the day. And so I personally stopped doing that, but I used to do it, and it just really was a headache for me.
Okay. Let's see. Now we have a couple questions on the actual treatment. Let's see. Do you intervene on CFV DVT that does not have iliocaval involvement?
Yeah, so that's a great question. So my comment to that is yes, because common femoral vein is proximal, and it's the main outflow from the limb up north. And so number one. Number two, most DVTs that are diagnosed, as we mentioned, by venous ultrasound, where they state that you have common femoral vein clot, but it's very rare that the ultrasound report has more proximal, like iliac involvement. And an ultrasound in and of itself is not as good in terms of accuracy to assess that. So I personally definitely approach patients with quote-unquote questionable isolated common femoral vein because of their risk of post-thrombotic syndrome being much higher than those who have just non-proximal DVTs.
Okay. Let's see, and how do you perform the angiogram? Is it always anterograde, meaning direction of flow, distal vein going up, or retrograde from proximal vein down?
Yeah, so generally speaking, as I mentioned in terms of technique, I almost always go with flow from from the popliteal vein up. That's one of the reasons I do that, is because when you inject, you're injecting with flow and you have good visualization of what you're dealing with. And number two, you're not fighting valves, which is very problematic in the femoral and popliteal distribution. So for those two reasons, I almost always access the popliteal vein when I do these cases.
Okay, great. let's see, our department tends to say, leave no metal behind. We're not big on stents. Does using EKOS tend to decrease the amount of adjunct stenting you need to do?
I would say for the vast majority, no. EKOS is used to remove the thrombus, but if you have a compression syndrome, EKOS or any type of pharmacomechanical technique does nothing to that. That's an external compression. It's a mechanical problem, and it can really only be treated mechanically by putting a stent. Some people have advocated trying balloon angioplasty, but my experience with that is balloon angioplasty for a significant venous compression syndrome is very inadequate. That area restenosis or recompresses very quickly unless you have a mechanical structure there not allowing the area to compress. So yes, I agree. Leaving metal behind in the common femoral vein or in the femoral vein, very problematic. Do not do that for the vast majority of cases. But if you have a venous compression syndrome in the common iliac vein, I think not leaving metal behind is very problematic. And really, stenting is absolutely the treatment that I recommend and is advocated in this distribution.
Okay, great. Next question, do you have any particular tips or tricks for using EKOS in upper extremity DVT, like Paget-Schrader syndrome?
Yeah, so upper extremity DVTs, if you have proximal involvement, axillary subclavian vein, SVC, I've done many cases in the upper extremity. I typically access the antecubital, so the basilic vein. Again, same type of thing. You're able to visualize when you inject by way of venogram because you're going with flow. And I use ultrasound to access the basilic vein. Once I do that, I usually put EKOS across all the way down the SVC, across the heart into the IVC, just to get, have complete coverage. And then I drip them overnight, and then on day 2, I take it out. I do venogram and assess. If you have like a thoracic outlet syndrome and you have severe stenosis at the first rib level, personally, I'll frequently do balloon angioplasty just to try to somewhat minimize the residual stenosis and get flow going. Then once that happens, I typically send those patients to a surgeon so they can have cervical rib resection, basically almost akin to treating the cause, which in the leg is May-Thurner. You want to treat the cause in things like for upper extremity DVTs like thoracic outlet syndrome by getting that rib resection so this doesn't happen again. But yeah, I've definitely used it and done it many times very successfully as a bridge to surgery so they can get that rib resected.
Okay, great. Let's see, next question. How do you manage anticoagulation after these interventions? And do you add ASA or Plavix in cases that require stenting?
Yeah, so as I mentioned, so typically on day 2 after the intervention is done, usually if stenting is done, there's actually a 10 French sheath in the popliteal vein. I typically have them pull the 10 French sheath once the ACT or PTT is appropriate per your institution's protocol. After that, I typically start the patient, as long as there's good hemostasis, on a heparin drip without bolus 4 hours after the sheath is removed. We do that overnight. Next day, and then of course they're already loaded with Plavix if they're stented in the cath lab. And then the next day, after that, I look at their popliteal site. If there's good hemostasis and there's no bleeding, I either switch them to a NOAC with Plavix for 2 months, or Lovenox Coumadin if they can't take a NOAC until their INR is appropriate. The other thing I do on day 2 after the sheath is removed and once their heparin drip is I put a sequential compression device on the calf of the affected legs, so that will allow flow to slightly be pushed up, and anytime you have flow, you minimize the risk of rethrombosis, and so I typically do that as well after the intervention once the heparin drip is started.
Okay, and let's see, we're getting close to the end of the questions. What is your surveillance schedule for ultrasound following DVT intervention?
Unlike the arterial bed, I'm not a big advocate of doing like absolute surveillance ultrasound. What I typically do, obviously if they have symptoms that warrant it, I typically get an ultrasound, particularly if they've had a stent, usually 4 to 6 months after, and then yearly after that. And there's no clear data to support or actually negate, using surveillance ultrasound. The arterial bed, we're much more stringent about using surveillance ultrasound for primary assisted patency. The venous bed, typically the clinical situation will mandate it or not mandate it, and so I personally don't do it except for in those situations.
All right. Well, let's see. I think the last question here is, you discussed 3 treatment options for DVT: EKOS, AngioJet, and AngioVac. How do you decide which treatment to use?
So I've used all of them, and I use all of them. So EKOS is definitely my go-to, particularly when I have extensive proximal involvement, because it's the most robust at really lysing effectively in an accelerated manner large clot burdens. AngioJet I typically use for people who have DVTs that are very acute within 1 to 2 weeks, with with involvement of basically common femoral vein and below. Once you start to talk about iliac or IVC involvement, my efficacy with AngioJet, or the efficacy with AngioJet for complete thrombolysis, in my mind, in my experience, is not as robust as EKOS. But I do frequently use AngioJet on day 2 with EKOS for residual thrombus or areas like within the distal femoral or popliteal vein that the EKOS catheter is unable to reach. And so I use it adjunctively. Now, in terms of AngioVac, it's a big undertaking. AngioVac is a large 26 French sheath with a 19 French inlet perfusion. You have to put the patient on veno-veno perfusion. It has its role because you don't have to thrombolyse the patient. You don't have to expose them to thrombolytics. But even with AngioVac, the usage of it is, in my mind, in my practice, is very, very limited for patients that can't get TPA, that have a very large thrombus burden in their IVC, and the use of it is not a simple undertaking, as I mentioned.
Thank you very much. EKOS would like to thank Dr. Safadi and our participants for attending today's webinar, Interventional Treatment for DVT, a Contemporary Approach. Once you leave today's webinar, you will receive a survey on the presentation. We would appreciate it if you would complete that and provide your feedback. We will also provide all the registrants with follow-up email on how to view the recording of today's webinar, which will reside on the EKOS website, and it should be available in 3 to 4 weeks. On behalf of EKOS and Dr. Safadi, thank you for joining us today.